Great. It looks like everyone's in the room. Hi, all. Welcome to the Operations Committee meeting, the committee subgroup of the Universal Health Plan Governance Board. Thank you for coming. This will be a lively meeting. We have 2 items to consider and vote on this meeting. But first, let's start off with a roll call. Please, Isabel.
Thank you. So Bruce Goldberg is on leave. Judy Richardson.
Here.
Thank you. Mike Leahy. Mike, I see that you're here if you're able to unmute. We can come back to
here.
There. Thank you, Mike. Laura Byerly. I don't see Laura yet. Doug Flo. I don't see Doug yet. Sarah Fouché, I know, is called in right now. So we've got her here. Lori Hoagland.
Here.
Thank you. Michael Horry, I don't see yet. Doris Karagu. Doris, are you able to unmute?
Yes, I'm here.
Thank you. Anne Lovejoy.
Here.
Thank you. Paula Weldon.
Here.
Thank you. That's everyone. Thanks.
Thanks, Isabel. And thanks, everyone, for participating in both the roll call and tech check. Great. All right. So here's our agenda this afternoon. We'll hear from our executive director, Dr. McDonald, about committee and board updates. We'll take a tour through enrollment revisited and see where we last left our heroes on the cliffhanger of enrollment and re-enrollment. Then we'll delve into subrogation with our stellar policy analyst and advisor, Lee Hastings. Talk about IT strategy. I know you've all been waiting for that one. And then we'll jump into the committee member reflections and next steps. Is everyone, we'll also do some public comment. Everyone okay with the agenda? Any changes to the agenda? All right, Dr. McDonald, take it away.
All right, thank you. Thanks, everyone. Good afternoon. This is Dr. Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. Nice to see you all and really appreciate everyone being here. I'm going to give a brief update. We had a board meeting. It was just last week, goodness. So the board spent a considerable amount of time discussing the proposed revenue strategy, and we're able to move forward on a couple of items specific to the revenue strategy, which was terrific work on the part of the board. The board also reviewed and approved a specialty care payment proposal. For those who are interested, coming up at the next board meeting, we'll be spending a lot of time talking about the flip side of revenue, which is the expenditure side of things. So that's on the docket for February 19th. So stay tuned. At Finance and Revenue, that very committee that created the terrific revenue strategy that is still under process of refinement as of yet, and some of the impact of the plan of that revenue plan has been discussed, but there's going to be more discussion on that. And then, excuse me, at the last meeting, there was also a review of the information that Milliman had presented regarding the initial expenditure, analysis from Milliman. Next, plan design and expenditure. There is on the docket coming up a behavioral health proposal. Yes, and also, which is kind of has been looked at a couple of times, and this is really more kind of some of the more administrative portions of it. And then also the plan design expenditure, we'll be looking at plan design and benefit options that are something potentially different from what has previously been discussed. So just kind of looking into that more in more detail. Our Community Engagement and Communications Committee has an update meeting this upcoming Wednesday. It's just an hour long to really keep them apprised of what's been happening. Our consultants, let's see, Diana Bianco from Artemis Consulting is working on those targeted engagement meetings and preparations for that. Those meetings are scheduled to happen in the month of March. And our other consultant, terrific one, Patty Wentz, is also working on some of the website updates that will be happening to give our website maybe not a complete glow up, but at least a refresh. So let's see. So that will be happening. And then the Community Engagement and Communications Committee is scheduled to sort of resume their regular meetings in March. And then lastly, but not least, the Transition Committee. There is a charter and work plan revision that has been happening that Lee Hastings has been heading up. And for those who don't know, our transition committee is going to be co-chaired by Judy Richardson and also by Mike Leahy. And also committee members, invitations have been sent out, and the committee members who are able to participate have let us know whether they can or not. So those folks, the process is that those people have to be, obviously they will all be approved, but their names go before the board at the next board meeting for approval, and we'll keep you apprised of what's happening there. So we can go, let's see if there's any questions or any comments. Judy, I don't know if you wanted to say anything, or Mike.
No, just thank you. It's hard keeping a pulse on all of the work going on, and I really appreciate it.
Thanks. All right, next slide then. All right, I get to turn it over to Lee Hastings.
All right, thank you so much. So we are really about to land the plane here on enrollment. So thank you all for joining me for what will hopefully be kind of making some of those final decisions so that we can pass this along to the board. Just as a recap, last time we talked about enrollment, we had it divided into these three sections: enrollment for new members, re-enrollment processes, and enrollment verification. This committee came to decisions on re-enrollment processes as well as the enrollment verification pieces. So we have that all tied up. Today we are just talking about that enrollment for new members, which I'll admit is the more complicated of those three. Next slide, please. So as a quick recap, again, we've been talking about these different enrollment processes, all the different ways that we can think about how enrollment can function. Everything from A, which is really our super simplified option where you have benefits covered immediately, to things where you need to essentially have that verification done before you're considered enrolled and can start using benefits, to having phased in benefits where maybe immediately you're eligible for certain primary care or care for chronic conditions, but not higher level work. Credible coverage, which is almost kind of can be ancillary to any of these, but related to those populations that are covered under federal programs, and essentially having them automatically roll in through those, as well as different benefits that might accrue to those that have been residents of Oregon for a longer period of time. Mike, I see you have your hand up.
Yes. First of all, this is a great way of looking at this. My question is, Lee, and it's I want a vague answer. I basically just want to know what's the financial effect of each of these five proposals.
I don't have hard and fast numbers for you, but I can tell you that if you look down at essentially those bottom two lines for each of these, that's where you're going to get kind of a sense of how they vary. And, just from my kind of top line review of these options, it's probably not really significantly different, but you'll see with some where there is kind of what we call the retroactive liability, or the verification before benefits. There could be some savings on that side because people aren't eligible right away. You're really taking the time to make sure, yes, they are a resident of this state. They're not just trying to, fly through and pick up some health care. Again, some small savings when you look at those phased benefits as well. That could change depending on how long you essentially keep people in that liminal space of you are only eligible for the basic set of benefits. Credible coverage is something that honestly probably doesn't have a whole lot of distinction, except it does help with the administration aspect. And then having other sort of tenure benefits, it's maybe some small savings from each of those. But when you look at the numbers impacted, you're generally talking about pretty small amounts because this is really initial enrollment. So we're not talking about people who already live in Oregon. Those folks are going to be covered as is. When we look at these, we're really just talking about, people that are moving into the state that are acquiring coverage for the first time.
Right. So I get that sense. So I infer from what you're saying that the ones that might have some fiscal effects, and they might not be major defined as more than $1 billion, that would be C and E, though would have some effects.
Yeah.
Okay. Thank you.
Yep. All right, let's move on to the next slide. So what I've done is I've taken these different options and I've tried to break them into sort of a flow chart of the questions that I'd really like this committee to answer. I think last time I had conflated a couple questions, so I really tried to pull them out so that you all could clearly see, what are we deciding and how they can be combined in different ways. So for instance, when is someone enrolled? We discussed options where it was immediate, that you could walk into an urgent care or a hospital. You could say, I'm a resident of Oregon, and they would cover you immediately just based on your attestation that you are a resident. We also discussed a process where you're not actually eligible until you've been verified and it's been confirmed by the public corporation that you are in fact a resident, that you've had all your documents reviewed, etc. We talked about distinctions between when are full benefits available, really distinguishing full benefits versus a basic set of preliminary benefits, that could be available immediately or that could be something that is phased in. And those two options operate really independently of each other. So you could have enrollment be immediate, but full benefits be later, or vice versa. And with this, I think I'll hand it over to you, Chair, to help us with discussion, if that's all right.
Thanks, Lee. Go ahead. Let's unshare so we can see each other. Does anyone have questions for Lee and the decision tree that's laid out in front of us? I think it might be helpful. Oh, yeah. Thanks, Lori. What's your question?
So I wondered if looking at other countries' plans, at the various ways that people could sign on, if they've done a little bit of analysis in terms of if you keep it simple, how much more expensive does that ultimately come out to? Because I'm tending more this time, after some thought, to wanting the money to go to care more than administration, and I'm leaning more on simplicity rather than complexity. So I was just curious if you've looked at that.
Do you happen to know, Lee?
I do not. I think it's a difficult study simply because countries aren't necessarily changing their enrollment process frequently enough to get that comparative data. It would be fascinating though, but I'm not sure it's out there in a super coherent
Do
form.
you know how many of them have a simple versus a more, what would the word be, graduated process? Because, I mean, if you move to Portugal, there's people going into the universal health plans everywhere, right, that are new.
Yeah, I do not. I could definitely look into that.
Mike, do you have a question for Lee?
No, just a comment on a few global things I'm aware of, and Lee started this one. There's a variance throughout the provinces in Canada, and they're minor, but they're there. There are some phased-in things in a number of areas. Depending on what your residency status is, like in Singapore, there's differences in Australia. Again, within each province, they are minor, but the people I know in those areas say that they've spent a lot of energy debating what's the right thing. The fundamental issue globally is having people move into your area so that they can get a basically major procedure free. That's what the issue is. It's financial risk issue. It's similar to what we might call adverse selection, but it's basically people coming into Oregon that strictly for the bone marrow transplant or the a major cardiac surgery, things like that.
Thank you. Other thoughts? Doris, you have your hand up.
Yes, I have a question. So I am also leaning towards immediate enrollment, but full benefits later on. Has it been discussed how long it would take before those full benefits kick in? 90 days, 120, because the longer it takes, the more cost it takes administratively.
We haven't had that discussion yet.
Sorry, ahead of the step. Sorry.
No, that's okay. That's the next logical step for sure. But we haven't, as a group, decided yet, even on this decision tree. So I'm hearing some interest in enrolling someone immediately following attestation. Does anyone have a strong feeling about having folks wait until after their eligibility is verified before they're enrolled? This is just enrollment. Okay. So if residents are enrolled immediately following attestation, when are full benefits available? And the next part of that discussion would be, there will be some benefits that should be immediately available, such as emergency benefits, right? But then other benefits may have a bit of a waiting period. And how long would that waiting period would we suggest? Doris, go ahead.
So I think I need an example. I'm an example type person. So let's say I live in Oregon. I've lived in Oregon for 30 days. And I come in and I say I want to enroll in this universal healthcare. But it shows, and after all of that is done, because it's done immediately, I'm enrolled. But then the verification process is underway as I have this health insurance, and then it's realized that, oh, I haven't lived in Oregon long enough. Does that mean then subsequently I'll have to pay back what was covered by insurance?
That's also a very good question that we haven't gotten to yet. Presumably, the benefits you might access immediately could be emergency benefits. We may consider primary care, establishing primary care, but complex care that will not impact morbidity and mortality by waiting would need a bit of a waiting period. And then the consequences of accessing care and then not being eligible is the next. I don't know if we need to come up with that solution as much as framing the first bit of the enrollment process. Hey, Lori, go ahead.
So a couple of things. One is that, I hear what Mike is saying. I think you could also handle some of that through the provider end, in that obviously if you're having a complicated surgery or chemotherapy or whatever, it would be by someone licensed in Oregon, and you have to establish care with that person, and you could make the provider and confirm that residency. And the worry I have, besides causing a lot of questions and complexity by setting these rules up, is that the healthcare workforce is already pretty wiped out, and PAs, all these extra steps that we build into healthcare systems, compromise the healthcare workers somewhat because it ties them up and they can't take care of patients as efficiently. So I think we also want to consider that impact as well.
Yes, thank you. Other thoughts about this decision tree?
I don't know if you can see, it looks like Mike has his hand up.
Thanks, Mimi. Go ahead, Mike.
Oh, just that in terms of context, as we proceed further along with the health plan, things will come up with all kinds of combinations and permutations. So I think our focus is to kind of get it sort of right. So for instance, on the example there, we might want to have something phased in, like for instance, by federal law, everybody's has access to emergency, but the question is, will they bill or not? And I'm just imagining here, but just this is illustrative, that maybe we might have a maximum $1,000 copay in up to 1,000 in the emergency. So I think that's going to be later for different kind of more sophisticated. This health plan is going to be obviously evolving, and as it gets established, people will be clearly tinkering with it, especially to figure out how to do, on the one hand, simplify it as much as possible, but on the second, not to get in a abnormal amount of whole new costs by having new type, very expensive services coming in. But when we look at how other countries or other provinces have evolved this, they've all made many different iterations in their first 5 years.
Thank you for that. Absolutely true. So let me propose a suggestion. Since we feel we are feeling some consensus around immediate enrollment following attestation, how about we think about, and this is not a motion yet, but I'm putting it out there for discussion. How about we recommend to the board that individuals are enrolled immediately following attestation, and then collaborate, get some feedback from Plan Design Committee, who's looking at the details and specifics of what's covered and when, and they can give us some input and feedback. They're a great committee that's been looking at this diamond from the other facet. What does everyone think? Paula. I can't quite hear you, Paula. You're off mute, but maybe a different speaker.
Sorry, I had my
Oh, there we
headset up. I'm fighting a cold, so I like that. I like the immediate enrollment after verification, but it's just hard. And I think that there should be some phase, but it's like, I don't know what, so yeah, I like that.
Thank you. And it's an immediate enrollment after attestation. Somebody just needs to say, I'm a resident, and then the verification process can launch, but they can go in and presumably establish with primary care and behavioral health or whatever plan design suggests or thinks about as they're looking for the plan elements in the design. Cool. Other thoughts? Would anyone like to make a
Doris has her hand up. Sorry, Judy.
Thanks. I'm on my iPad today, Doris. Sorry.
I know, those are so hard.
I can't see. Go
It's okay,
ahead.
I'm also on a different computer today. It's a little funky. But yes, I would like to make a motion to vote on Judy's proposal.
Oh, bless you. Is there a second? Thank you, Lori. That's a second. Isabel, will you go ahead and do a roll call? And just for the record, I'll restate the motion. It's not Judy's motion. It's to recommend to the governing board that enrollment should occur immediately following attestation.
Great. So Bruce Goldberg is on leave. Judy Richardson,
Yes.
Mike Leahy,
Yes.
Laura Byerly is absent. Doug Flo is absent. Sarah Fouché,
No.
Lori Hoagland,
Yes.
Michael Horry is absent. George Karagu,
Yes.
Anne Lovejoy,
Yes.
Paula Weldon.
Yes.
Thank you. That's 6 yes and 1 no.
Thank
So-
you all very much. I'll work with Helen. I'll let her know that this is coming to the board and ask for her engagement on plan design to inform that next part of the decision tree.
Oh, and Sarah. Sarah has her hand up. Please, Sarah.
Sarah, please go ahead.
Oh yeah, just want to quickly explain my no. I would love to see the phased benefits idea fleshed out due to the migration concerns and cost concerns.
Absolutely. That's the second piece of the question that that vote did not include. So yeah, we'll definitely work with that. Thank you. All right. And apologies, I didn't call for discussion prior to taking the vote. Shame. Mimi, are you ready to talk about subrogation and workman's comp?
That's still Lee.
Yeah, that's me again.
Oh, thanks, Lee.
Yeah, Isabel,
You get a
can we
two-
get the slides back? Thank you so much. All right, so we are going to chat a little bit about subrogation and workers' comp, two related but somewhat distinct things. So subrogation, in case you don't know what that is, I didn't know what it was a few months ago, so don't worry about that. Subrogation is essentially when a third party takes responsibility over a claim. So you're going to see this in insurance a lot. Those prime examples are listed at the bottom there. This is very common for auto insurance, for casualty property insurance, as well as for malpractice insurance. This is a doctrine that allows those insurance companies to quickly pay out those claims to cover any healthcare expenses that are related with the injury, and then to pursue reimbursement on behalf of the injured party. This reduces individual financial burden, so it's from a policy perspective, a pretty solid doctrine because it allows them to get that treatment they need right away, and also to not have to bear that cognitive load of actually going after, whoever is potentially at fault for the injury. Subrogation does tend to lower insurance rates because it really enhances recovery. Again, because insurance companies have folks that are specially trained in how to do this, they're a lot more efficient than an individual trying to pursue their own recovery when this is something that, for an individual, hopefully only happens once a life. So we wouldn't have that expertise, insurance companies do. Therefore, they're able to do this a lot more efficiently. Next slide. So this plays out a little differently depending upon what the health insurance company is. Again, subrogation is kind of interesting because you're technically trying to collect that payment from a third party that is considered to be at fault for it, but you still do want to, get that immediate treatment. If you've been in a car accident, you're not going to sit around and wait before getting your injuries tended to. When it comes to private insurance here in Oregon, especially for auto accidents, we have what's called a made whole doctrine, which essentially means that any funds that are recovered first go towards making that individual whole from kind of a medical sense. So those claims, those dollars immediately go towards that care first. The insurer can only then claim amounts that are above what has essentially made that person whole. So that's a pretty strong protection that we see on the auto side. For non-auto claims, so this would be something like a property, a slip and fall would be one example. That's often inferred, but it's not quite as explicit. But in general, Oregon courts treat insurance, private insurance, as needing to make the individual whole, medically speaking, before they can take any additional amounts. Medicare is a little bit stricter, to be honest, probably the most strict of these various payers. So they are a secondary payer when there is anyone else that needs to pay. So that includes third-party liability coverage as well as workers' compensation. Any payments that are covered by Medicare that are determined to fall in that category, Medicare can actually recover from the individual. They are not bound by any made whole amounts, so it is possible that if you're covered by Medicare, you could end up owing the federal government money in this respect if they decide that they improperly covered care that should have been paid for by somebody else. Medicaid is, of course, more in line with state doctrine here. Medicaid does require that the individual's medical costs are fully compensated before it can start to take any of those excess funds. So very, very similar to that made whole doctrine that we see on the private insurance side. Mike.
Maybe this is a leading question, Lee, but first of all, this is really helpful. My question is, as we imagine we're going to be a universal health plan, and I'm just, having you to help us think through how would a universal health plan that is covering all people, how would this handle it? Like, for instance, would it be bound by made whole rules? Would we need additional legislation, if you will? So, I recognize I'm asking, I'm in the weeds with you there, Lee. I really like how you've described this, but I'm wondering how it'll affect what we're trying to do.
Yeah, thank you for that, Mike. Your $10 will be in the mail for teeing me up for my next slide here. So I will get to your question specifically, Mike, but I do just want to touch on,
Right.
as we are thinking about exactly what you brought up, how does this liability coverage function when we have a single payer? And kind of the general rule, I put that in quotes because it's something that I just sort of generated out of my research. But what we typically see in this regard is that a single payer covers those medical expenses the same way it would cover anybody's medical expenses, but it does use statutory rights to seek reimbursement from any potential individuals that might be liable for those injuries. So with regards to would it require statutory change, it would certainly require that the universal health plan have a statutory right to seek reimbursement on behalf of individuals that are injured due to the negligence of others. So that would definitely need to be a part of the structure if we were to go a similar route to what we see other single payer entities doing. So on the left side, we have a few examples. We've got the UK as well as a couple of the Canadian provinces that all sort of demonstrate this this principle where someone is injured, auto accident, slip and fall, whatever it might be, they can go to the hospital, urgent care, they will get coverage, and that universal payer will cover that. The universal payer then noting that, this was the result of an accident and there might be liability, will separately pursue reimbursement on behalf of the injured patient. So the patient, kind of similar to what we see with insurance today, doesn't have to get involved in that litigation aspect, or at least very minimally. The kind of technical aspects would be handled by the single payer, or in these examples, are handled by the single payer. They have departments that pursue liability claims and collect it. Now on the other side, because I'm sort of a policy wonk, so it felt important to me to kind of call this out, just that there are really good policy reasons for structuring things this way. First and foremost, cost efficiency. There is real money to be recovered through subrogation, through allowing payers to recover from wrongdoers. I know some of it seems like not very much when you look at, the U.S. private health insurers that they recover about 0.2 to 0.3% of benefit payments. That does not sound like a lot, but you know, this is healthcare. We think about things in terms of billions. Even here in Oregon, if it's not a $1 billion problem, you know, it's maybe too small to be, you know, like for our board to consider in a super comprehensive manner. Like that's the scale we're talking about. And so when we're thinking billions of dollars, that is some real money that can be recovered through this doctrine. Additionally, there's this concept of moral hazard, very popular in tort law, but related to, you know, you want to discourage people from doing risky things like driving without seatbelts on or driving too fast, you know, or not. I lived in Boston for a long time, you know, not like clearing the snow and ice from in front of the brownstone. You want people to be good citizens, and part of doing that is having some of these liability doctrines in place that hold people accountable for risky or reckless types of actions. Mike, did I answer your question? Before I move on, I just want to make sure.
Yeah, for today, but yeah, basically, yes. I think you and I will do a follow-up on this.
That
Thanks.
sounds great. Mimi.
Yeah, I think the only other part that I'd add to Mike's point, or just to bring it up, is of course a lot of it depends on what is agreed upon in the waiver. So oftentimes, that there are regulations that are, you know, put on by CMS. So for example, CMS may very well say, no, you must continue for the Medicare population. You must continue to use these rules, or some financial penalty where I'm like, or you can pay for it if you want to, but you're going to get this much fewer amount of money. So I think that that's just another consideration. It's like just another layer that is just another layer.
Yes, thank you. Always have to remember the federal government. Lori.
When I have worked as a provider in primary care with people who have experienced auto accidents, the care is really different. There's a lot of writing notes for people to get off of work. And there's sometimes people choosing to go to alternative therapies. You know, I don't know exactly at this point, obviously, who all the providers might be that we cover. But like for trauma experiences, people might choose to go to a rapid eye movement therapist. And so I wonder a little bit how, you know, handling strictly the medical piece and not working working with different, I guess, vendors on the other pieces. I'm just having a hard time envisioning that.
Judy, I don't know if you had any thoughts. I guess my thought immediately went to, I think some of that is a question about the benefits that are available and the extent to which those alternative therapies are an option, and therefore it's hopefully more integrated, more consolidated. But I am speculating, so Judy, I'll let you chime in.
Hadn't quite thought about it. Anne.
Yeah, just generally subrogation is used when there's two insurers who both cover the same person. It isn't normally tied to treatment, it's normally tied to coverage. Or in the case of the moral hazard that's listed here,
Mhm.
if someone's driving drunk, there's culpability there.
Mhm. Yeah, and maybe I'm using the term incorrectly. The way that I intend it for these slides that I've presented is when there is a liability decision. All right, seeing no questions, I think we will move ahead. So we have just discussed essentially liability coverage. We're now going to turn to workers' compensation, which is another one of those systems where a third party is paying for injuries. What's distinct about workers' compensation is it is very explicitly a no-fault system. So there is no blame assigned in this particular case. It's also broader than just medical care. And I know that other kinds of liability can be broader as well, but workers' compensation very specifically covers medical care as well as compensation for lost wages and other types of things related to the fact that their actual ability to hold down a job has been impacted. So it is a broader scope of services that is offered. This is also something that, there are a lot of tie-ins to how it's structured with employers in order to give employers an incentive to maintain safe workplaces and to be financially accountable for the amount of risk in their workplace. So a lot of administrative and legal differences that we see in workers' compensation and in third-party liability. Now, when it comes to how various single payer systems treat workers' compensation, it's both it's similar and different, I'll say, to what we see for the third party liability. It's a lot more distinct. So as opposed to before, where a lot of the single payer systems would cover the medical expenses and then essentially act as the insurer working with the liability carrier. In Canada, Germany, and Norway, they're mandated to, be involved in these systems, and it does tend to operate more as a side by side rather than something that is truly integrated. So in Canada, for instance, we see that there is a special board that pays for those medical costs of the work-related injury, not necessarily integrated with that single payer of the province. In Germany, workers' comp is very specifically outside of the medical system. They have what they call various pillars of their social system. Workers' compensation is its own independent pillar. Yes, and kind of a similar thing for Norway here. So we see workers' compensation in this case is really on a parallel track and not so much integrated. Where they are sort of coordinated, though, very clearly in all these respects, is there's often rate coordination between what the single payer pays and what is paid through the workers' compensation system. But otherwise, they're not intermingled, in large part because of some of those ancillary payments that are made to compensate for loss of a job and not wanting to kind of confuse which funds are for which purpose. Next slide, please. So I just wanted to provide you all kind of a score sheet on how Oregon's workers' compensation program stacks up. This information is largely drawn from the Workers' Compensation Research Institute, which, looks at these 4 categories when it's evaluating the different systems. So these seem like a good set of systems or a good set of metrics on which to share with all of you. So employer costs, essentially how much this costs for employers to pay those premiums. Oregon has consistently done very well in that top quartile. So very, very strong in terms of its cost efficiency overall. With regard to benefits, Oregon sits pretty solidly in the middle. So, not necessarily the richest, definitely not the poorest, a very, median kind of amount. Administration and delivery and the system reputation, though, these are the areas where Oregon really, really shines. It is consistently like number 1 through 3 on these 2 metrics. So for that administration and delivery, it's really considered a model to other states, particularly for how well it manages litigation and costs associated with that. As I'm sure everyone's aware, litigation is really, really expensive, and that's probably part of why our system is so cost effective. And then reputation-wise, Oregon is really leading the way with respect to issuing reports and having metrics and really making its data available. And it's not just about putting it out there publicly, but that it really uses its data to drive policy changes. So it's really seen as a leader in that space. And other states actually study what Oregon issues and have been trying to build similar kinds of dashboards and reports to monitor their own states, because we have really, really impressive systems in that regard. So as you can see from kind of all the little green dots that I've given it, our workers' compensation program is pretty darn strong. It is a high functioning program relative to the US states. It's, I would say in the top 10%. Next slide, please. So just by way of summary, when we're talking about that kind of liability coverage, as mentioned, we typically see that single payer universal systems cover that medically necessary care just on an automatic basis without regard to liability, but they do have statutory cost recovery rights that allow them to pursue reimbursement from those insurers or those that might potentially be liable. Overall, that practice is to try to separate, receiving healthcare from liability fights in that regard. So making that healthcare automatic, not something that has to be worried about, but allowing some financial recovery where it is appropriate. On the workers' compensation side, even where we have really robust systems, we tend to see it operating on a parallel track. There's coordination with respect to what is paid in order to avoid any kind of strange incentives that might happen about whether someone's in workers' compensation. So definitely coordinated, but operating as its own kind of entity with its own infrastructure, etc. And that is everything. Mike, I see your hands up.
Oh, just a thought. One of our board members who is now on leave is, still involved, I believe, in workers' comp. And I was just wondering if you had consulted with Bruce Goldberg about. I'm thinking in terms of kind of this, what would be the structural relationship of a universal health plan and what is a very good workers' comp system right now, but just helping us, think this through. I was wondering whether we've done that, or it's a suggestion. Maybe one of you might want to have a conversation with Bruce if you haven't.
Yeah, I was not aware he had that background, so thank you. I will definitely follow up.
Thank you so much, Lee. I always feel smarter after I listen to you.
I think there's just one more slide on what we are hoping this committee will vote on. Lori, I see your hands up too.
So, for people who might be working under the table kinds of things with workers' injuries, I'm not too aware of how they're handled currently in Oregon. I'm more familiar with California, but how would that, be discussed in here to make sure, because our goal with this universal health plan is really to level the playing field and make, everyone able to receive the same care.
Ooh. Gosh, that's a tricky question. I feel like I'd have to research more workers. I'm not quite sure how the state handles that.
Can I ask the question, Lori, what do you mean by under the table? You mean people are providing care and not billing for it? Or
No, people who are working that because of the nature of their work relationships, they don't have workers' comp coverage. So when they get injured on the job,
work injury. Got it.
Yeah.
that's all. Because we wouldn't really want to create, those would probably mostly be lower income jobs. And, if they didn't have the same opportunities, it would create problems, I would expect, in this system.
Well, I have a clarifying question, though. Aren't there labor laws against those kinds of practices?
Almost definitely. I'll just put that out there.
Yeah, I don't think it applies to the health insurance. It applies to the employer.
But when you're, dealing with a whole state of employees that have different circumstances, different options, how we would, I guess, make it such that everyone's entitled to, solid medical care regardless of what the workers' comp piece is or isn't.
Yeah, and I think under a universal health plan, to the extent an employer was doing something illegal, which hopefully they're not, and there are definitely penalties for that, the workers' comp might not kick in, but they would continue to have the coverage under the universal health plan.
But when I think about this, I think about the situation where you're having your childcare provided by a nanny, where you probably don't have workers' comp, or you're contracting with a high school student to come and do yard work. I mean, there's a lot of informal work injuries that happen outside of ignorant about this, so I'm just bringing it up as possible problem.
Yeah, I guess what I'm not understanding is like, do you foresee a risk in that just because these are things that happen today? So I guess like um what's the hazard you're trying to avoid or concerned about?
Well, I guess when I'm thinking about it, these probably have to be handled legislatively in terms of, if a person gets unpaid leave away from, there's other aspects to helping a person get over work-related problems besides just the workers' comp piece. So I guess just thinking about right now, we know people have different levels of care depending on their personal circumstances because of the way our healthcare system works. And I was just wondering, what kind of maybe free thinking about how work-related injuries would be made whole given the differences in, people's work options.
I really love that you're turning this over, Lori, and trying to look at it every different aspect. The way I think about this as a clinician, I think, gosh, this is going to make my life so much simpler. If somebody falls off of a ladder while they're picking cherries, this happens all the time in my neck of the woods. I'm just going to take care of them, and hopefully they're, they've been enrolled and registered and they have universal health care coverage, and I don't have to worry about stopping what I'm doing in the exam room and saying, oh, sorry, this is a workman's comp issue. You have to go back to the front and, go through the whole registration process in my clinic because it's a workman's comp claim. And that happens all the time too. And it is a hassle. So I'm hopeful, at least from the patient perspective and the provider, the clinician provider perspective, it will be much more seamless in delivery of care. And now on the other side, like figuring out who's responsible, for paying compensation for the worker who can't work and stuff. I'm glad that's not part of our scope. Yeah, Mike.
Well, I just wanted, Lori, to thank you for your observation because there actually is a whole host of, there's the off the books economy, right? And when we know we focus a lot on looking at groups, but there's based on my old experience at Kaiser, there's about 10% of the Kaiser members that were individual members. And when we did some private survey things, it's amazing how many people that buy individual insurance that are people that are being paid off the books. So you're bringing up a great point, which is we have to study how this works out. Like, for instance, if we're trying to get revenue from a tax structure, but it's from people that already are working off the books, we may slightly overestimate the amount of revenue we're going to get. It won't be based on the population here, it'll based on the number of taxpayers. So you really raised a very thoughtful point, and I thank you for that.
Thanks, Mike. And I would like to point out in the chat, thank you, Mimi, who brought up that Oregon law requires almost all employers with one or more employees to carry workers' compensation insurance or be self-insured. And coverage is active from the first day of employment to cover injuries, illnesses, or death arising from work. Thank you. Other questions or discussion? Maybe we'll let you go to your last slide.
All right. Yeah, so with that in mind, kind of this whole discussion that we've all had, we have essentially two recommendations that we would ask this committee to consider or to challenge us on. The first being that workers' compensation and other liability systems such as auto and malpractice that provide funding for medical expenses should continue to operate independently of a universal health plan. So auto insurance would continue to be auto insurance, workers' compensation program would continue to be the workers' compensation program. However, the second piece is that the universal health plan would use process of subrogation or statutory right of recovery in order to collect appropriate funds from workers' compensation or from liability entities in order to remove that administrative burden from the providers. So the providers would continue to be paid through a universal health plan. They would be responsible for feeding some information up, but the UHP itself would pursue that reimbursement, that rate of recovery, if available.
Thank you, Lee. Any discussion or questions about these suggested recommendations to the board before we take motions and vote? First one is don't mess with Oregon workers' comp because it's great. We'll be like Norway. The second one is everybody's going to get killed.
I think Lori had her hand up first, then Anne.
So if we are living in Oregon and working outside of the state, I mean, have we, just wondering thoughts about having a state-based care system that, with the workers' comp coming out from outside the state.
Where subrogation comes in, go get that Washington workman's comp. And
I agree with both of these proposals. And one of the reasons that they're both good is because there are processes and precedents that are already well established. So we're not having to reinvent the wheel.
love. Other thoughts? Sarah, you look like you're thinking about something. Okay, just want to make sure to give you time to speak. All right. Would anyone like to make a motion?
Lori does have her hand up. I don't know if it's for a motion.
I'm sorry, I'm stretching these conversations out a little
Oh,
bit.
it's okay.
So now, like, say, for instance, has its own clinics where people with workers' comp are handled. So how do, just imagining we're transitioning from our current system to a new system, and the goal would be to have the universal healthcare system handle the medical component of it. And I'm still having a little difficulty understanding how the relationship, for me, when I'm taking care of people with, injuries, musculoskeletal problems, there's always the issue of time away from work to heal. And, that involves negotiation in terms of, and that part of the reason why they don't really want us to deal with workers' comp, I think, is because would probably make it more complicated and more expensive than people who deal with it every single day. But I'm just having a little difficulty understanding how we work collaboratively if we're doing the medical piece and then the other part is handled separate.
I was wondering about those occupational health docs who specialize in workman's comp. Mimi, do you have some thoughts about that?
Just that I think Lori was wondering about it because I think it's certainly not described or completed. We don't have a complete thought about it, but it's a start. Partly because Oregon does have such an incredible workers' comp system. I mean, truly, they do so much more than even than taking care of people. They have a whole preventive workforce that goes out and does all kinds of other work. And I like Anne's comment that like these systems are highly functioning. So you're absolutely right, Lori. It will take a lot of discussion. I mean, we can envision like, well, maybe there's going to be some video visits involved. I mean, you know, there's no free lunch. It won't be perfect, but because it is such a highly functioning system, I think that it would be that this is a starting place for discussion to work with our workers' comp people that we have here in Oregon. And exactly, I love the way your mind works too. You like think of all these potentials, which are true, which absolutely need to be worked out. So we're at the very beginning building blocks. I mean, I think Lee laid it out really well, but yes, so many thorny questions.
And I do feel good when you say that, Mimi, that, you know, we have a strong system, and I definitely feels better putting these recommendations out there, knowing that we aren't going to have to put together a workers' comp system at the same time.
You know, it's not a stated principle of the board, but it's kind of been our practice to see things that are going well in Oregon or things that we've learned from and pulling that in and leveraging that to rather than trying something new from scratch that has to be built and made mistakes with. Other thoughts?
I move that we adopt both of these recommendations.
Thank you, Anne. Is there a second?
I second.
Oh, thank you, Paula. Is there any discussion? Isabel, would you go ahead and take a roll call vote?
Yes. Bruce Goldberg is on leave. Judy Richardson,
Yes.
Mike Leahy,
Because I think we're going to be disruptive enough in a lot of other pieces of our work, I vote yes.
Laura Byerly is absent. Doug Flo is absent. Sarah Fouché,
Yes.
Lori Hoagland,
Yes.
Michael Horry is absent. Doris Karagu,
Yes.
Anne Lovejoy,
Yes.
Paula Weldon.
Yes.
Thank you. That's all yeses.
Thank you, everyone. Strong work. We'll make these recommendations to the governing board. All right. I think now we're ready for the information technology strategy. Mimi.
All right, everyone. I recommend you either take a drink of some sort of stimulating beverage, whether caffeinated or not. I would like to preface this with potentially no surprise to any of them. I am not an information system specialist. However, I still think that we are able to have a conversation about this. There are a couple pages of a glossary. It will be difficult not to gloss over them, but I think that we will be able to get to like the meat of the discussion. So just bear with me. Stop when you have questions or when it looks like, I don't know that that's exactly correct, or you'd like to provide a correction. So having said that, let's dive in. So we'll go to the first slide. Yeah, this is going to be the best slide because it's the the least amount of verbiage on it. But one of the most important things I think we need to talk about is if we're discussing an information system, what is the scope that this committee would like to comment upon? What is the scope that this committee would like to make a recommendation to the Board of Econ? Because of course there's like the list of everything in the world. So we'll talk about scope first. I did provide a glossary because it's almost impossible to talk about some of these components without that. And then what I wanted to talk about is when we think about an information system strategy, and definitely would love more input for this, what makes up an information system strategy as we're talking about it for a health plan, and what are we missing? And this is really, this could be, and especially I know we have some just experts in this arena. It doesn't, you don't have to be an information technology specialist to know what makes a good strategy. So I'll talk just a little bit about what a roadmap might look at, and then just really hoping to bring together a discussion of all of those components. So on to the next slide. All right, first, so just to talk about the scope, and taken from the work plan, the scope for this committee was to identify information technology needs, also including the cost benefit ratio of a statewide health information system, and then provide recommendations to the board regarding information technology needs, and also the requirements from participating providers. So obviously, so there's a couple of times there is definitely more than just a payer side to a system and a provider side when we think about the healthcare system, because of course there's a state side and a federal side, and then there's a possibly other agency side. So, but to think about this again, not just the payer side, but also all the other entities that are going to interact. So that's the scope. So what I'd like the committee to ponder as we're going along, I mean, one of the things that, and you'll possibly get my bent from this because the title of this is Information System Strategy, is that what this committee might propose to the board is truly a strategy and not a system itself, right? We're not going to be able to, or it is, I would say, in my opinion, more reasonable to provide a strategy than the actual nuts and bolts and specifying what system or what vendor or things like that. But I want people to think about that when we talk about a strategy. Another component to think about is time frame, the time frame of the committee getting their work done, but also the ultimate time frame of what we're talking about. Is this something that can an information system be set up in 6 months? Does it take a year? If it's a statewide thing, will it take 3 years? And then also, what types of resources? And for this, again, thinking on 2 levels. One, what does this committee need for resources just to help put forth a proposal to the board or recommendation to the board? And bigger picture, what types of resources are needed for a statewide system? So there's a lot of meta things seems to be going on. So a little bit more up in the clouds than some of our other discussions, but I know that this committee is ready for it. So taking a deep breath, let's go on to the glossary. I know. Now, some of this, there will be no test. And some of this, I'm absolutely certain people have familiarity with. The first one, which I suspect everyone on this call is familiar with, is HIPAA, the Health Insurance Portability and Accountability Act, 1996 was when it came. And so for some people, perhaps they think of HIPAA as more of the challenge, but it really is to protect sensitive patient information from unauthorized access. So it really is, if we think about it, it's really not meant to prevent people from getting healthcare. It really is meant, or to be an obstacle, but it's meant to protect confidentiality. And along with that is the next thing, 42 CFR, which is, or Code of Federal Regulations. So that has specifically to do with around substance use disorder. So there's some very specific regulations around that. And confidentiality is going to be a huge part, and protecting information is a huge part, of course, of this information system strategy. All right, the next one, and this one I think is something that if you are not familiar with API as an acronym, I do think this is important just because in my reading it came up so many times. Application of programming interface, essentially how do the software talk together and exchange information. And again, as I talked about, we could have like the most fabulous single system sort of from a payer side, but if it doesn't talk to all the other systems, it will not be beneficial. I'll go a little bit more quickly through these other things, just to give people an idea about it. TEFCA, Trusted Exchange Framework and Common Agreement. So it's a US initiative, and it creates a standardized structure for health information to be shared. So again, and we'll just have these as, we may have to refer back to them. So we'll go on to the next slide. These ones we are going to go through quickly. QUIN, Qualified Health Information Network. So QUINs are sort of work underneath TEFCA. So they work as hubs, and sort of a hub and spoke information sharing. The next one I frequently hear it referred to as FHIR, like you'll see like FHIR 7, Fast Healthcare Interoperability Resource. So it's an API focused standard. It's essentially, it is a standard which things, systems have to live up to. And so I think I told, or most people know that I was involved in as a health plan, and they had to, things had to be essentially upgraded to be able to get to this standard. There's some other things, USCDI, in case you see it, that's just core data for interoperability. We can go on to the next one. I'm hoping this might be our last one, but I'm not sure. Again, NCPDP, people probably are familiar with that. National Council for Prescription Drug Program, which has actually been an incredible program about the electronic exchange of prescription information. X12, never heard of it before, but it is, it's a electronic data exchange for business documents. And then there's the NIST, which is a US government agency that helps develop these standards and technology and best practices. One more, I think. Phew. High Trust, Health Information Trust Alliance. They are a nonprofit that sort of provides certification to help organizations manage risk. I have never heard this said out loud, so I'm just going to say that it's SOC2 type 2. Maybe people say it differently, or maybe they say SOC. I don't know. That is, however, that is a rigorous audit that agencies have to pass through. So looking at security, processing, integrity, and other things. And lastly, almost, we have one after this. So ACA section 1557. So this is just a provision of the ACA that prohibits discrimination on the grounds of race, color, national origin, sex, age, or disability. And again, as it pertains to certain health programs. So the reason I have all these acronyms in here is the systems will have to be in compliance with all of these regulations, which is another key component. And then now we get on to the last one, which, if you've never seen this before, Zero Trust, which sounds very dramatic, but it's a cybersecurity model based on the principle of never trust, always verify. So I think, and again, this is just from my reading, is that it had been in the past possibly that things within a network, there was less verification, less scrutiny on it. Now I think that has changed, because as we know, it's so easy for networks to be infiltrated. And so hence you will see a couple of times this zero trust. So that's what that is about, kind of like just built in security in multiple levels. Okay. I think that was the biggest part of it. And now we're going to go into actually what's more of the fun stuff. So let's talk about components of an information technology strategy. So big picture, what are things that we want to do with this system for the universal health plan? Well, we want everyone in Oregon to be able to be enrolled and to serve them. And we want to make sure that all of their information is private and secure. Now, what I'd also like to say is this is not, this is an example of an executive summary. So this isn't our executive summary, but these are the kinds of things that go into one. So as we go through this and we think about this, so for example, enable real-time insights. Well, what does that mean? Well, what it means from a provider standpoint, there you are thinking perhaps that this person should have an MRI for their acute back pain. And you have, because there are some restrictions on advanced imaging, some prior authorizations. However, instead of having to submit a prior authorization to somewhere else and wait and have it come back literally in real time, fill in the information, bing, yes, this is approved. Great, off to scheduling they go. So that's kind of the real-time insights that we're one tiny example of it. But again, when we're thinking like, okay, what do we want out of this system? Next, I talk about integration with all of the other agencies, providers, things that are involved within the healthcare system. Next, well, we want it not just to be able to enroll people, but as a universal health plan and the keeper of all of this data. One would want a system that is able to pull out important components, important measurements, to identify areas of challenges, and to be able to, if there is a change in a practice or a system, to see if that actually improves outcomes. So that's another huge thing, sort of an ask or a want. Then there's all the compliance things, hence all of those names. And then lastly, the ability to adapt. As we know, things are going to change constantly. And so you can't have like the best system in the world that will become obsolete in 2 years. Well, you could have that, but that would be unfortunate. Okay, so any other thoughts about things that people like, boy, in my dream world, and you could be on the provider side or the payer side, what would I want in a healthcare information technology strategy? Okay, you don't have something just yet. Think about it. Ooh, Mike, fire away.
Okay, I've given this some thought, so I guess I have 3 things for us just to begin to introduce or to consider. The first is AI, and that is that it's likely it'll be a basic and pervasive ramifications for everything we're doing here, right? So, and examples of that might be regarding providers. It also, I would suggest, might be a lot more in terms of the 4.3 million Oregonians that are going to either use ChatGPT or are going to use something. And so one of the things we have to think about or suggest is that wouldn't it be nice if there was a credible, evidence-based, usable information system for all Oregonians, and how that might transform the whole role of the consumer. So I suggest we outline and then refer to the transition committee to study this after we have a more fuller strawman universal health proposal in March or April. But that, at least for today, we acknowledge AI will be included in the transformation work this spring. So that's my first point. My second is that as we're trying to think beyond, Mimi has given us the basics. Beyond this is do we want to get into a transformational IT strategy? Because I think that should include a basic strategy for the single payer, but I also think we would be missing an opportunity if we didn't state that we need an Oregon statewide health information IT structure that includes interoperability. It includes provider, not only EMRs, but health information. It would include consumer health education. It would include health promotion capabilities. And finally, knowing that a number of you appreciate taking real life examples, I've told this story to Mimi, but to reflect on it. So a gazillion years ago, I had been appointed the health director for Alameda County in California. So, and my responsibility was for the public hospitals and public health, mental health, etc. And one of my mentors, Dr. Henry Blum, who was a actually a health officer for the Contra Costa County, but a full-time professor at Berkeley. I was telling him I'm struggling about how to figure out what really is the role of the county. And this is a county of almost 2 million people. Uh, and he said, Mike, think of it this way, that you have, I had been at Children's Hospital, and the hospitals and the doctors there in the community each had their own perspectives, if you will. He said, now you're not only operating these public hospitals, but in a sense, your role is to think about, well, if the health system is doing such and such, what really isn't it doing? Okay, so from our perspective, that might be it's the uninsured, it's the others. So we, one of the, and I've learned this, 4 decades ago. So I'm sharing with you. I think as we approach an information technology and we get the basics right and we try to transform, it's important to think about this as if it's a whole new world of a universal health plan, but also we'll have to work collaboratively with all the existing resources. There's got to be a lot of changes, but there's a lot of opportunities once we can look at the entire population of Oregon and use AI and use a very robust system. Those are my 3 points. So take it away.
Thanks. And Judy, did you have a comment that you wanted to make?
Mike's comment just made me think about data governance and data and AI governance, and maybe that it's implied in the list of strategies, but maybe should be explicitly called out at some point. The strategy.
Absolutely. Thank you. Lori, please.
I guess the other thing that is very topical right now is the vulnerability of having every resident of our state, all their personal information in a place that federal government may want to take information from. And I guess this whole long list of protections, perhaps. And, my hope, of course, is that by the time we get here, we won't be worrying in the same manner that we are right now. But how are we going to, it's kind of scary to think about the fact that we would have every single resident of our state gathered in a place that someone could take that information from.
Yeah, that's such an excellent point. Thank you. Yeah, and actually that goes well into the next slide. So, which is, so that was sort of the executive summary of the whole thing. But this is again something else that I really would love this committee, and apologies because nobody had the opportunity to look at it ahead of time. But we will come back to this, is that this idea of guiding principles. Again, these are just examples. This is not a proposal or anything. This is just things that are that other agencies have taken up or things that are recommended. And so you can see, of course, like people first and equity is a huge consideration. As we know, data collection can lead to tremendous inequities depending on who the data is being collected from and how it is being used. So, and then privacy, absolutely. And then you also see that zero trust security. And it's kind of some of the things that go along with what was in that executive summary. But I think really, I think that this committee in particular can really, I think, pull out, and as we think about these guiding principles, and if people, have other things on their own, modularity, I talked about that, and reusability. I've definitely been places, I won't say where, but that has millions of dollars and then did not actually end up using a system, or it was for a very short term only. Observability and outcomes, resilience, definitely, and sustainability. I also think interoperability. So I don't know if people have other things they'd like to add to this list. There are certainly, again, this is just a first pass through of things for people to think of. Yeah, Mike.
I find it ironic, right, that one of the major things that have evolved is about zero trust security. So that's fine from a protectionist or control perspective, but I think the most important thing is that the system needs to be trustworthy and that we can trust in it, and that there's an maybe opportunity for one simple system to begin to rebuild trust, if you will. So there's some element about trust and trustworthy that I just feel we have to include somehow in a strategy.
I like that. Thank you. I think that is a really good thought. All right, going to the next slide. And I will go through these a little bit more quickly. I don't think we have to call them all out, but so now what I'm sort of talking about again are these components of an IT strategy. So we started, we had there's a summary, we had our guiding principles, and then next you just have to think about, all right, who all is involved? I mean, essentially everyone, yes, because if everyone who lives in Oregon is eligible or has a use for this, then you will want to have an interface that everyone can use. So it's a huge thing to think about and could be such an amazing sort of win for a universal health plan. If you think about all of the terrible websites any of us have ever been on, and what it would really be like. I mean, just imagine if you clicked on a button and you actually knew if a provider was taking patients for realsies, as they say, it would be phenomenal. So again, it's a little bit of a dreaming and there's a lot to it, but there is that potential. I've got Mike in my head now thinking of the way that things could be. But again, so thinking about partners in the ecosystem, obviously what's happening around it. Next slide. And again, please, anytime anyone jump in, throw up a hand. We've talked about this a lot, and so I'm just going to put this slide up there, compliance and risk framework. I had never heard the phrase until I worked for a health plan, but health plans are inherently very, very, very compliant organizations. And there's a good reason for that, but it cannot be stressed enough, the importance of this. Next slide. All right, so this one is definitely a stretch for me to be able to explain everything, but I think, we're talking about the different components. Now we're really almost, although it's still virtual, we're sort of getting into kind of bricks and mortar land a little bit, about now it's like the very different parts that give you all of that interoperability, but give you that security, and what do you need within that. So you need platforms and infrastructure. You still need that security, data and analytics. Oh my goodness, so important. And it seems as if, well, if all the data is in one place, then it's no problem. But that sort of work absolutely must be built into it. All right. And then another interesting thing that there are within, for example, if there's a universal health plan, obviously the care is certainly by the providers, but when we think about it, it is incredibly beneficial to be able to have that population health level oversight. And so that's where you get some of that higher level analytics, but then also, so you are able to but then also to zoom in. And so then that you can get into very specific instances or specific areas of perhaps there is a person who is needs assistance with their care. Maybe they live in a region where they can't get care. I mean, there's a million examples, but that is one of the things that makes this type of thing so tricky. You need to be able to zoom out and zoom in. Next slide. Goodness, I only highlighted some of them, not all. I'm so embarrassed. Data governance and privacy. Absolutely, Judy, you alluded to this. I don't know if will you like talk a little bit more about this, and I'll examine my life choices about why I don't highlight all the bullet points I mean to.
No, sorry, I didn't mean to jump your slide. No, I was just thinking about, to your previous slide, what happens to all that data? Are we going to allow research to be done on the data? Like, whose data is it? How do we, going forward, talk about and think about the bumpers around AI use and judicious use and ethical use? And so, like, from a strategic perspective, where does that governance live, and thinking about their ongoing work, because it's not like, build it and you're done. It's governance and just as you have here, stewardship and feeding and weeding, that takes a group, an entity, and it's absolute work that needs to be called out.
Thank you. Lori, yes, please.
Well, I would think, and maybe this is something that Mike can speak about. Kaiser system is a system that they pull a lot of information from patient data, and I don't know what kind of guardrails are there in that case, or what they've learned from that experience. But I do know that having worked for Kaiser, that they use a lot of information from patients.
Thanks, Lori. Mike, do you have thoughts about that?
Sure. Well, I'll give you an example of this, not when I was at Kaiser, but after I helped to form OCHIN. So OCHIN, I think you all know, and we'll introduce Abby Sears to you all at a future date, who now runs OCHIN. OCHIN, as we were establishing a database, and that was essentially for the community health centers, the public health departments, if you will. After a while, both the Kaiser people that I'd worked with and also OHSU, where I then was a clinical instructor in family medicine, were very interested in the research aspects of the OCHIN database. And your observations are very good about, well, how much do you allow Kaiser full access to database? How much do you allow such and such? So all I can share with you is that it's a very long story. There's a lot of complexities. A lot of it has to do with integrity and trustworthy and respect. We've got to be very careful, for instance, that we won't have examples like the Epic people have shared this with me, that they became aware that there were some lawyers that were getting inappropriate to some of the databases so that they could mine it for getting prospective, looking at electronic records to get prospective clients, so they could get clients that could then sue for X, right? So this is an enormous topic, and one of the reasons I was suggesting that we stay at a high level and then refer to the transition committee is that we have to be pretty clear about what is it that is going to be the plan's architecture, and from that we can develop, I think, a robust information structure, and then the governance of that information, very important. And we've got to at least suggest that by the time we write our full report and present it in September, we have thought about how is this going to be governed, how is it going to be protected, and at the same time, how can we make this as an incredible opportunity to improve healthcare in Oregon.
Thanks, Mike. And Paula, please.
Wow, it's this. So, I agree with all that. And I think that first slide that you showed, because I work for a HIE in Oregon, and we connected the Epic systems, the public health, we connected individual providers. They're all on different systems, and they don't want to change. And that's a huge effort to change providers. So their systems, it'd be better for us to, we're meeting them where they're at, the systems that they're already using. And then we had purpose of use. We had people come to us to say, hey, we'd like to, because we had gathered all the data. So it's one thing to belong to TEFCA. That's just moving the data around. And it's another thing to have a database where the data lives. So there's each system has their own member, or not member, there's member IDs, but patient IDs. How do you make sure that it's Paula Weldon in all the systems? Those are things that we took on as an HIE, so I have some experience with that. But I think what I go to is because I always want to solve it, like, oh, you know, but back to your first slide of what do we need to accomplish, which is more of these are the things that we should be able to do out of the strategy, right? So me personally, I just, sorry, I'm fighting this cold. So I want us to think about this some more and look at these slides that you put together to see if I think there's something missing, but there's, anyways, I'm really excited about this part. So I don't know what I just said, but anyway, a lot of thoughts.
Wow, you're my new best friend, Paula. Thank you. I know I didn't even get into data warehouses and lakes and pools and all of the other ways that data lives, because I knew I was definitely in over my head. So absolutely, I'm grateful that you took my presentation. Someone who has so much experience with it is willing to kind of consider it more. So I'm gonna go on to our very next slide, which I think is probably the last one for this. Oh, nope, second to last. Keep jumping the gun. Okay, again, this one is truly, well, what could happen. But I think what was interesting to me that there is this, I mean, 36 months, when I think about it, that's actually, that still seems pretty fast. I mean, I think that too, when we consider the enormity of a project like this, and of course it could be less than that, 18 months, but I think that this is so crucial to the success of the universal health plan, like cannot be overstated. And when we, you know, again, thinking about this timeline and thinking about just first steps, and maybe those first steps are how could one get funding to study what to do? I mean, that, like, I'm talking like really first steps. So but I just thought I'd put this out here to talk about that, just that there's so much work that this would involve. And I think that, again, sorry, just saying it over and over again, but I think that there's a lot of attention that will be focused on this. So probably won't get completely done in 2 months, the whole plan for everything with this committee, but it's a place to start. So now I think we get to go on to my last slide. Yay. So I'm actually going to turn this back over to Chair Richardson. And I'm so grateful for the attention everyone paid for this. Thank you. I didn't, and if anyone nodded off, they did it when they were off camera. So thank you.
Thanks, Mimi. I thought it was a great presentation. And Paula, I hope you get over your cold soon because you are awesome. And I'd love for you to help lead these discussions as we go forward. This is not my native language, and it takes me, I'll confess, a while to digest it and think about it and really think about my experience and how that biases me, and then what am I not seeing. So I'm going to reserve any other judgment other than just stating my gratitude. And this feels like a really good start at thinking about a strategic framework as it relates to IT. How is everyone else feeling? Are you missing something, or is there something you wish you had so that as a next steps from this committee, we can really digest and get into this, thinking about developing an IT strategy? I'm going to thank you in advance too for thinking about these slides. And then we can really frame up a solid discussion and launch pad at our next committee meeting. This committee is remarkable in the amount of work that we all get done and what we bring to the table. And so I really appreciate learning this process from you, hearing a subject matter expert or bringing someone to the discussion who teaches us something, and then we really noodle on it and come back and get ready to make a recommendation. And that bodes very well for the transition committee as well. I think we will need to lean on a lot of experts, both for implementation science, but as well as subject matter experts who will need to inform the committee, who can then make recommendations. questions, thoughts, comments? Anything else to add, Mimi?
I think Mike has his hand up. Please, Mike.
Thank you, Mike.
Well, this is just maybe a teaser answer to what you just said, Judy. We know that our universal health plan needs to provide, essential coverage, but it also needs, in terms of IT, it needs to be flexible to note gaps, access, bottlenecks, inequality in rural versus urban areas, the resiliency of the hospitals and health systems and providers, and to applaud things when they're working, but also to make adjustments. And I mentioned Dr. Blum, my other mentor. Remember, I'm the old person on this group here. Is a guy named Don Berwick, who taught me about continuous quality improvement. And IT needs to provide the interoperable connectivity. It needs to monitor real-time information capability. Those are elements, I think, that are beyond the basics of an IT structure. That's the exciting stuff that actually could really improve healthcare for all Oregonians. So I'm looking forward to that work, and I'm absolutely pleased with all the comments today and thoughts that are forced me to think some more about this topic. So thank you.
Thank you, Mike. Yeah. Let us not forget the greats that have come before us, and Don Berwick is definitely one of them. Other thoughts or reflections, comments, questions? As you're digesting this between committee meetings and a question arises, please send an email to either me or Mimi or both of us, and we can direct it to staff as needed to find an answer, and then help to bring some more information to the table so we can have a really solid, informed discussion next month. Okay. Any other general committee member reflections? Got next steps, some homework. Lori.
So, with regard to the conversation about the signing up for the health plan and at how long until we started is to how we would graduate the services with. When are we going to address that? Is that going to be part of this? I was just curious.
Thank you, Lori. My hope, and Mimi and Isabel and Lee, correct me if this is too aspirational, but what I would really like to do is connect with the plan design committee through the chair and ask Helen to get them to noodle on this question too, and then bring their thoughts back to us at our next meeting, and then we can provide a part two to our recommendation to the board. I do want to push this recommendation about enrollment, immediate enrollment to them, so that they already know we're discussing this, and that our recommendation is that folks be enrolled and not wait for verification, but that we are having the discussion and trying to collaborate with plan design about when do those benefits come on board and when do they kick in at our next meeting. Thank you. Any others? Okay, hearing none. Isabel, do we have a public comment, or?
It doesn't look like they're here today.
For the committee, there's a letter in the packet available from Luz. Oh, no, it's from Tom. From Tom. Please take a look at that letter. That letter went to all committees and the governing board. I believe Helen will summarize those during the public comment section of the board, but please take a look at that. Anything else for the good of the order today? Hi, Paula, go ahead.
Sorry, I just thought of something. Mimi, or at least in the HIE world and the IT in that world, we called them Q-hins.
Thank
Cue-
you.
cue
Thank
hen.
you. I knew. I'm like, I know there are going to be some. It's going to be like a cute thing the way you're supposed to say it. And then I
Just
got
thought
it.
I'd
Cue
mention
his.
that, but
I
yeah.
love it. Now I'm going to sound a lot cooler.
Paula is making us
That's all.
the cool kids among the IT geeks. I love it. Anybody else? Friends, thank you for your time this afternoon. I really appreciate it. I just sing your praises to the other committees and the governing board about how efficient and productive this committee is. And I think the reason you are is because of the work you put in before coming. And so I really appreciate that. Yeah, we'll be in touch soon. And if not, we'll see each other on the Zoom. Sarah.
Oh, yes. Paula, when you talk about HEI, I'm not in the cool club. I don't know what that acronym is.
Oh, I'm so sorry. Yeah, health information exchange. So, yep.
Thank you, Sarah. That is for anyone watching this recording and for the public as well. When I did work on the CCO board, we used to have a little jar that wasn't a swear jar, it was an acronyms jar. You have to put a quarter in every time you let one fly because not everyone speaks the alphabet language that we do.
For the record, though, I think anyone who's on this committee is in the cool club. So consider yourself in, Sarah.
Yeah.
And anyone listening too, actually.
But we can't improve on that. So with this, I'll adjourn this committee meeting. Thank you, everyone. See you again soon.